Hey everyone, I'm just going to give it a minute to let people join that are probably hopping over from another meeting. You guys seeing my screen okay with the slides for Pathways? Perfect. Always like to double check. All right, it's 1:02, so things are starting to level up a little bit. So I think we'll get started in the interest of time. Just want to thank everybody for coming today to the next quarterly meeting for Pathways for Kids. We're really excited to have our presenter, Dr. Todd Glensky from Children's Mercy Hospital, presenting on ERAS. So we're excited for that presentation. We were just going to go through a few things before we get to that presentation. All right. You still seeing? Oh, yeah. All right, as far as the things that we're going to cover today, I'm going to drop in the chat the information for Slack. We moved our communication platform over to Slack, so we do encourage everybody to join there. And if you have joined and have not filled out our member intake form, we recommend you do that as well. So I'm going to drop that information in the chat. We'll go from there. Right, but if you have any questions, you can reach out. We're happy to get you all connected. Then we're going to have our ERAS presentation, hopefully have some questions answered and some meaningful discussion. We do have Jared Dustin from our team is going to be talking about a patient engagement and clinical pathway development survey. And then we just have some steering committee updates to share with the group. All right. A little bit of a lag here. All right, so I just dropped this in the chat, but we'll also be sending this out and it'll be available on the website if you have questions or need to access these links. All right, and with that, I can hand it over to Dr. Todd Glensky. I'm not sure if you want to drive your own slides, whatever you prefer.
Perfect. Can you guys hear me? Start with the microphone. Yes? Okay, perfect.
Yeah.
Sorry, I'm a Teams person. Let me request control and see if I can get my slides up.
I think we enabled it, so you should be able to share, but I do have your slides. If it's easier, if you want me to just pull them up, I'm happy to do that, and you can let me know when you want to pass along.
All right, I'm going to start sharing. Can you guys see that?
Yes.
Okay, perfect. All right, we can see this? I can't see you guys now.
Yes, we can see.
Okay, perfect. Please interrupt me if you have a question because I really can't see you. So my name is Todd Glensky. I'm an anesthesiologist here in Kansas City at Children's Mercy. I'm also a medical director in our Department of Evidence-Based Practice. And I'm going to talk a little bit about enhanced recovery after surgery. So thank you for the opportunity to discuss what we're doing here in Kansas City. So it's just kind of an overview of the talk. We're going to discuss what is ERAS, how we create pathways here and how we implement them in Kansas City, what our data collection is, how we present data, who we present it to, and when we present it, all important stuff with ERAS. Some of the academic endeavors we have done along the way, and then definitely we've learned a lot of lessons in the last couple of years doing this. I have no financial disclosures. So ERAS, kind of at its core, it's basically an evidence-based pathway for surgical patients. I know we're all involved with pathways. I'm not sure how many people are involved in the perioperative world, but these are really pathways for the perioperative patients, really designed to optimize and enhance the recovery of really any surgical patient. Like all good pathways, they have to be multidisciplinary in the approach. You have to have multiple teams. You really want someone from every aspect of the care that these patients get, starting in pre-op clinic and ending when they come back to surgery clinic. A lot of core concepts in ERAS. Some of them are preoperative education, preoperative nutrition. There's obviously stuff kind of on the day of surgery, how anesthesia manages the patients. Pain management is really important, multimodal analgesia, nerve blocks, and then after leaving the ORs, returning to diet early, mobilization, and ultimately getting patients out of the hospital quicker. Again, like all of our pathways, we're really trying to minimize unnecessary variation in care, knowing that there's going to be some variation between patients, but really minimizing how teams are approaching these patients. And again, increasing communication between teams, important in everything we do in the hospital, vital in ERAS for it to work. You can't just have, an anesthesia department focused on this. You can't just have a surgery focused. You got to have a bunch of teams who are invested in this. ERAS is not new. This was the first article that kind of started describing it. This is back in 1997 in the British Journal of Anesthesia. It was first described in adults for abdominal surgery, has absolutely been mainstream in adults for at least a decade, definitely becoming mainstream in pediatrics. You started seeing peds publications about this probably 5 to 7 years ago, and you continue to see a lot of stuff coming out in the peds world. Enhanced recovery after surgery, it's absolutely, in my mind, a quality improvement in nature. This is not a research project where you do something, study it, and then release the results. These, to be successful, require PDSA cycles, constant management, constant data analysis. This is not a set it and forget it type entity. Talk a little bit about how we do it here. So I think we are lucky and probably a little unique that evidence-based practice serves as the coordinator for all of these pathways. Our gastric sleeve was our first one in 2021. And I will say before that, there were some ERAS pathways that had been developed in the anesthesia department, but really were more of what goes on in the operating room. They didn't really touch on preoperative care. They didn't touch on postoperative care. There definitely was efforts around standardization in the OR. But since we've kind of taken charge in EBP, it's really, truly, the whole spectrum of the patient visit, which is really important to make this stuff successful. I think we have 10 current ERAS pathways right now. We just finished our idiopathic spine a couple of weeks ago and released it. As you can see, I listed them all there, and I listed them because it's important to see that there's definitely different surgical groups who are involved. So we have a couple with our general surgeons, the gastric sleeve, the colorectal. Urology is obviously with our urologist. We have our heart center and cardiac surgeon involved in one. Our orthopedic surgeons are involved in a couple, sports medicine, complex ortho, cerebral palsy, and spine, plastic surgery, cleft palate, and then we even have our OB-GYN colleagues who developed one for endometriosis patients. All of our ERAS pathways are housed on our website, and it's externally facing, which is great. We'll talk about access of these pathways, but it's really important for people to be able to access these easily and quickly. And so they're all on our website. Pathway creation, like all pathways, I know that's what we all do. You have to get all the key stakeholders involved. You have to have champions. So evidence-based practice, we are obviously champions of this, but we can only do so much. And so we really do need other anesthesiologists to be champions. We need our surgeons to be involved. We absolutely have to have our APRNs throughout the hospital invested in this. And so a typical team will be a program manager from evidence-based practice. It'll be me as the medical director, and then surgeons, anesthesiologists, surgery APRNs, anesthesia APRNs, inpatient nursing, absolutely nursing from same-day surgery in our recovery room. We've had ICU nursing involved. The table right there just shows the people who were involved in our cardiac surgery one, just to give you an idea. So we had 2 anesthesiologists, one of our heart surgeons, an intensivist, a cardiologist, and a whole host of APRNs that are basically at every stage where these patients go through. ERAS starts in clinic. So absolutely a key component to this is having patient and families be engaged. So the discussion of ERAS hopefully begins in our surgery clinics when they are scheduled for certain surgeries, and definitely begins or continues at our pre-admission testing clinic. Important to introduce the core concepts to the families, really talking about some baseline expectations. Historically, people were NPO till midnight for all surgeries, and that's changed definitely over the last 15 years or so, but that stigma is still out there. And so we really have to emphasize with our families, we want you drinking, and we want you drinking up to 2 hours before your surgery. And then additionally, we want you drinking carbohydrate-rich fluids. Lots of evidence to support that. There is no reason a child or an adult at this point should not be drinking Gatorade before a surgery. Believe it or not, that is challenging to get out, challenging to message, and we have really poor compliance with it when it's something we track. I'll talk a little bit more about that. We definitely talk to the families about pain management. You're going to get regional nerve blocks if it's appropriate. You should expect to be having acetaminophen and ibuprofen, stuff that some families may not expect to actually get in a hospital stay. And then obviously we want teams working towards discharge goals with the families. Again, not such an obvious thing for some families. A kid who comes in for heart surgery, their family may think, man, this is a huge surgery. This kid, my kid could be in the hospital for a week. No, we change that expectation. Hey, we want your kid out of the hospital as quickly as possible when it's safe. Right here, as you can see, one of our handouts. So we try and deliver handouts to all of our patients and families when they come to clinic. We have them in multiple languages. The one showing here is our generic handout. And again, kind of goes through some core concepts of what to expect before surgery, the morning of surgery, during surgery, after surgery, follow-up, to kind of get the families on the same page as us. We definitely have some specialized handouts. We have a separate one for our cardiac patients. We have a separate one for our pectus bar. And again, patient and family engagement it's really important for this. Here's an example of one of our preoperative care algorithms, and it's for our cardiac surgery. And it's not so much to focus what's in there, it's just to show that we do have preoperative stuff for all of our pathways. It's really helpful for our APRNs to follow in clinic. I think we have, just in our pre-admission testing, we have 8 APRNs who work up all of our patients in clinic, and cardiology probably has same amount. So it's really nice to get all of them on the same page. Especially when it comes to ordering labs, radiology. This one is really specific about what medicines do we want you to take? What medicines do you need to hold before your heart surgery? Just as important, we have up there, hey, drink your carbohydrate-rich drink 2 hours prior to surgery. Preoperative bundles, that's stuff we track. So we do track which patients do follow the directions for carbohydrate clears. When do they stop drinking? There are some of our pathways the patients get medicines in same-day surgery, like scopolamine for PONV prophylaxis, Lovenox, diazepam. And so all of those are integrated into the different preoperative pathways that you'll see. Intraoperative care. So again, this is just an example of one of our ERAS pathways. This is our neuromuscular patients undergoing major orthopedic surgery. So these are basically cerebral palsy patients having big lower extremity hip and leg surgeries. Like I mentioned before, these things absolutely have to be accessible for users, or people will not follow them. And we have learned that the hard way. And so we have made it in the operating room really, really easy to pull this stuff out. Just like any academic center, we have rotating residents from multiple residency programs coming through here who have no idea of any of our guidelines or pathways. And so we really make a concerted effort to make this accessible, also to make our learners know that these things are out there. Just an example of some of the intraoperative bundle stuff that we track. And I will say none of this stuff is groundbreaking. This is all should be standard of care, all very based in evidence. So, appropriate antibiotics, were they given before incision? That's something we track. Did you get appropriate PONV prophylaxis? Did people get Decadron? Did they get Zofran? Multimodal analgesia. Did you give IV Tylenol during the case? Did you give Toradol? Some of ours require a bolus of ketamine or a Precedex infusion. Especially for this one, normothermia is super important. These cerebral palsy kids get really, really cold really, really quick. And so that's a metric we definitely focus on. Did you deliver your patient with an appropriate temperature when you got to the recovery room? minimizing long-acting opioids. That's kind of a core concept in, just perioperative care at this point, but definitely part of ERAS. And euvolemia. You do not want to volume overload anybody on major surgeries. The one thing I want to focus on the picture there is the box in the middle on the bottom that says regional anesthesia. These surgeries, like I said, they vary between what parts of the leg are they doing? Are they involving the hip or not? So there was a lot of unnecessary variation of care in how we did nerve blocks with these patients before we rolled this out. So we worked really closely with our pain doctors, as well as some other anesthesiologists, really coming up with a standardized way to do nerve blocks. You see a lot of oars in there because, in anesthesia, there's a lot of new nerve blocks that have been kind of released to the world in the last 5 years, and not everybody knows how to do them. And so we had to also be cognizant of that some people may not be comfortable doing all of these different blocks. And so we definitely had some leeway in there, but this was definitely an opportunity to where people were kind of all over the place. Some people weren't even doing nerve blocks. And now we've really standardized how we approach these kids and their postoperative pain management. This is an example of postoperative care. This is from our cardiac surgery ERAS. This is the CICU. And really, it's not so much to focus on what's in there. This is more of a, once these kids leave the operating room, it can be challenging. So for me, especially because I'm an anesthesiologist, it's really easy for me and my department to control what goes on in the OR, obviously. And it's really easy for us to control what goes on in our PAT clinic. And it's really easy for the surgeons to control what goes on in, cardiac surgery clinic. But the second they're out of our recovery room or they hit the ICU, it's a whole other world where the buy-in really just may not be there. And it's very challenging to get buy-in outside of, the immediate OR area. Some of the metrics that we track in the post-op world is, same as intra-op, multimodal analgesia. Our patients getting scheduled Tylenol like they should, ketorolac, ibuprofen. For the cardiac surgery one, we track extubation time, the total amount of time in the cardiac ICU. One of the APRNs on the floor had said, hey, I think we were leaving our chest tubes in too long. And so we started tracking that. And now we have decreased our chest tube time, which is wonderful for these kids. We track when do they first get their first PO, when are they getting diet orders, how are they getting out of bed, and ultimately length of stay for hospitalization. Just like the pre-op one and all our intra-op ones, the post-op ones definitely look different depending on what service line we're talking about. Some of our service lines, like the sports medicine one, there's really not much post-op. Those kids are going home on the day of surgery. And so the main focus was preoperative and intra-op. The cardiac surgery one is very focused. This is the CICU one, which really ultimately all of this on here, the goal is to get the kid extubated and get the kid ready to move to the floor the next morning. And then there's a floor one also, which the goal is ultimately get that kid out of the hospital as quickly as possible when it's safe. Data. Data is huge in all of this. So it's really challenging to get buy-in from people if you can't turn around and show them data, whether it's good or bad. And again, we learned that early on very quickly. At this point, like I said, we have 10 different pathways. And so we have 10 monthly reports coming in. They, unfortunately for me, they all come in on the 15th. So my email is full this morning. They get sent to me and then some of the other key stakeholders that were involved in the creation. The creation of these data reports has we've spent a lot of time on it over the years. Having a dedicated IT person is helpful. I say that we don't have one. We've had 3 over the last probably 3 years, and the most recent one we've had for about 1.5 years. And I feel like we finally hit a cadence for when we create a new one that it's not that challenging to get the data. We use Cerner. I'm not sure how hard it is for other EMRs, but it is not easy for us to get this stuff. We have to get it from different places. The anesthesia record is different than the main Cerner database. The heart center at our hospital doesn't even enter a lot of the data in Cerner. They enter it into the STS reporting. And so it takes time, and it's really helpful to have the same person with you when you're creating this. So we get all these monthly data reports and we enter them into their own kind of growing database. I won't go through all the examples up here, but you can see, case information. Obviously, you want to track all of that. This is the preoperative one from our sports medicine, the yellow there, and it tracks what the patient's last clears are. So we had to create a checkbox for our same-day surgery nurses to to be able to even document carbohydrate-rich clears. It used to just be clears or no clears. Acetaminophen, oxycodone, diazepam, again, we're tracking the drugs that are in those preoperative metrics. The Interop bundle, this is for sports medicine. Again, it's nothing terribly exciting. It's PONV medicine. Did you avoid morphine and hydromorphone? Did you give Tylenol, ketorolac, ketamine? Did you get a regional block? If so, what kind was it? We have the end of the block time. That is there because we actually track how long it takes to do our nerve blocks, which is something the surgeons were interested in. Temperature, antibiotics prior to incision. Post-op, very similar to the Interop. We're just tracking some drugs, and then length of stay. This is the pectus one for the post-op down there. And, we're very interested in if the patient needed an overnight admission or not. In these growing databases, we have to make a lot of calculations on our own because the reports can't make them. So this is just an example of some of the calculations that we make on our cardiac surgery patients. We want to know the length of the case. Did they get PONV prophylaxis? What was the Interop compliance? I will note that says 1. It's either 0 or 1 the way this works. You either met all the components in the bundle and you get a score of 1, or if you missed 1, you get a score of 0. And that's the way we have kind of looked at bundle compliance. That's definitely not the way it has to be done. Time until extubation, again, is an important one for cardiac. Time in the CICU, time until chest tube removal. So this is just an example of the data we're pulling and kind of what we're doing with it. Which leads me to the next obvious one. How do we present this data? Who do we present it to? Like I've said before, you really have to keep your stakeholders in the loop. I would push back is a strong word, but we've had some people who have said, well, show me what we're doing is making a difference, or are you even tracking this data? And it's really nice to turn around and say, yes, we are tracking this data. So this is a table for our pectus bar, and this is what kind of all of ours look when we put the data together. You can see that the first column is just patient characteristics and some of the metrics we track. The second column is our baseline data pull. So this is baseline data before we release this, which we do also on all of our ERAS. You have to have some sort of baseline to see if you're making any sort of substantial change. And then we break it out every 6 months. So we get monthly reports, but we compile all that data on a 6-month cadence, which is about the appropriate amount of time we feel like it is to send back to your teams. I'll talk about the carbohydrate-rich clears. I'm not sure if you can see my mouse or not, but it's the second one under preoperative care. And you can see our baseline was 28%, which is marginal. And we rolled it out, and our carbohydrate clears went down to 15% and then kind of bumped up to 26%. And this is a really good example of when you kind of got to put the brakes on something and do a PDSA cycle. And you cannot do a successful PDSA cycle without having good data. And so we sat down with everybody and we quickly realized what the problem was. Our pectus patients are, for 99% of them, are too healthy to come to our pre-admission testing. And so they were getting instructions for carbohydrate-rich clears at their surgery clinic, which is great, except sometimes that's 3 months before their surgery. And so we really worked with surgery clinic to ensure they were getting the handout, but probably more importantly, we worked with our same-day surgery and PACU nurses, who are the ones making the phone call 48 hours before surgery, basically saying, hey, this is when you need to show up for surgery. And we emphasize that it's really important that you also start talking about carbohydrate-rich clears to these patients. And they did, and you can see the next 6 months, July to December of last year, we bumped up to 42%. Not great in my book, but still a lot better than we're doing. I'll go talk about one more thing, and it's underneath that, the intraoperative care, where you see all 9 components. Like I said, we look at it kind of as an all or none. And then people in my own department were like, that's a little harsh for a pathway that has 9 things. And especially when the compliance is 62% from July to December. And so we decided to, I wouldn't say, make it easier, but we started including if they got 8 or 9 components. And that number jumps up to 90, which is pretty good. 90% of the patients got 8 or 9 of the components of the intraoperative bundle. And again, that's how we have decided to look at it. You easily could look at it as total bundle elements compliant and not as an all or none phenomenon. With this, again, you have to find a balance in reporting it. We've had to send out emails as reminders, say, hey, don't forget to do this. It seems more recently we're sending out positive reminders of, hey, look at how great everybody is doing. Keep up the good work. You really have to find a balance because there's 10 of these, and we want people to read the emails, and people get a ton of emails. And so it's hard. So sometimes I go back to the team and say, hey, do you want to share this, or you think we're good? And that has been helpful. I have no advice except that it's challenging because again, I get 50 emails a day, and so I want people to read these emails when we get them.
I'm sorry to interrupt before you transition slides. We just had a comment in the chat just asking if you could take it out of presenter mode. It's just a little bit small for people to see.
Oh my gosh.
If you
I didn't know it was in presenter mode. I don't know how to do that.
If you want, I'm happy to share my screen if that works. And you can let me know when you want to pass from there. Does that work? Do you want to stop sharing?
Or you can also press on the 1, 2, 3, 4th icon. Oh, it's gone. Never mind.
Am I done sharing? I can't even tell now. Sorry.
It looks like you still are. Let me see if I can.
Sharing this way is a little bit bigger if this works.
How's this?
Todd, we've been able to see things, but
I can send. I'm going to send this out to everybody. But is this better?
Yeah.
I can't tell what you were seeing. Okay. I will
And
send
Todd,
this out. Yep.
While we're paused, there was a question about the possibility of automated data extraction from the EHR, generated like automated reports, and that would be more real time, and of course save you time.
Let me. I think I have 2 slides left, but that is a great question, and I'm gonna not be sharing when I talk about that. All right. Can you guys see this?
Yeah.
Yes.
Okay, perfect. So we take all of that data, and ultimately, this is what we've been working on for a while, is we turn it into dashboards. And so instead of me sending emails out or other people sending reminder emails out, we have this dashboard at our anesthesia huddle board, which is really nice. So this gets addressed probably once a week as one of our stewardship metrics. And I'm not sure what kind of huddle boards people have out there, but if you can get this stuff to a huddle board, I think it's way better received. And again, there's nothing on this that wasn't on the table before. It's just it's presented nicely. And so we're in the process of really getting dashboards for all of ours. To make it presentable to people outside of ERAS, to administrators in our hospital to show what we're doing. But again, to not have to send out these emails reminding people, you got to just build it into your culture. I can't emphasize that enough. And again, this just has our preoperative care, intraoperative bundle, and overnight admission and length of stay with our Pectus-Bar patients. And I will say our length of stay has dropped dramatically. These patients, traditionally Pectus-Bar patients stayed in the hospital up to 5 days, getting thoracic epidurals. The surgeons now do, at least at our institution, do cryoablation, which is incredible. And so we with the surgeons saw an opportunity to say, hey, we think we could, if they got the right amount of stuff in the operating room, we could have the potential to send them home the night of. And we're now sending 67% of our Pectus patients home, which is an awesome improvement. A little bit about academic endeavors. All of this stuff is publishable. Again, I think of it as QI, and so you can view it as research. So at our institution, all this stuff is QI, meaning that it's gone through IRB and exempt for everything you would need for research, which makes it easier for us to publish at meetings and poster stuff. And so this is a picture just of our fellow who presented our Pectus-Bar at our national anesthesia meeting in San Francisco. But we've published a couple of things. Most of the publications for ERAS are going to be in an anesthesia journal or a surgery journal, but I definitely think there's opportunity outside kind of those domains for publications. One more slide. So ongoing and challenges. So we've had a ton of them. Again, institutional buy-in is huge. And I would say, I think we're grateful at our institution that EVP is here and we've taken ownership of it. It definitely lends some credibility to it, as well as, our group here is really unbiased, as opposed to, if it was just the anesthesiologist leading it or just the surgeons, people come to us. And I think that's made it very successful. People are always resistant to change. My way is the best way. I haven't heard those exact words, but I hear that stuff all the time in the operating room. And so again, data is great to have to show people that maybe standardization of some things is better. Important stakeholders are left in the dark. Since we make Pathways, I'm sure everybody has gotten that dreaded email when you release something where someone emails you and says, why wasn't I a part of that? I've gotten those emails about this. So we're super cognizant of really trying to include everyone that these patients may encounter. Another important one, pathway implementers aren't aware a patient is part of a pathway. Again, it's great to have a nice looking pathway. It's great to track all of this stuff, but if people aren't even aware it's out there, then they're not going to use it. Again, we've done a lot of stuff to get this information out and really make it easy for people to use, and that's really important. Data, I think I've spoken enough about that, and we'll talk more regarding that question, but I think it's super important to have really robust and ongoing data. And I would say this is probably the biggest downfall. You forgot the PDSA cycles are relevant. I think I'm just like everybody else. When I finish a project, I'm super excited to go to the next project. And you just can't forget about these once you release them. It really does require these champions out there, and it requires time, energy, and resources, all of those things for these things to continue to succeed. And there are always going to be opportunities to make improvements after you've released it. And that's the data part and getting feedback. We've had multiple ways we have changed our pathways, from feedback from nursing, which was not data driven, but it was really great to hear. And then we've changed some stuff purely because of data. And then closing the loop with stakeholders. Again, I don't have the magic solution on how to do that, except that at some point people like to hear when they're following something that, it's doing good. I think that is all I have. Thank you guys. Sorry I was in presenter mode the whole time. I'm gonna stop sharing. Here's my email address, and please email me with questions about anything. All right.
Todd, this is Jason Miller from Boston Children's. It was terrific. Thank you so much for sharing. Well put together and organized download. I have one question, or that's come to mind, is you guys have, I think you said 10 of these now, and that you're covering data on all of them and stuff like that. What's your pipeline of new ones coming like, and how are you prioritizing that pipeline? Do you have like a method to that, or are you kind of just going with the people who are the most excited to work with you?
I think a little bit of both. Like when we started doing these right off the bat, I knew we needed to do a cardiac surgery one because our surgeons were interested in it. And Boston had just published a really cool paper about how they implemented one. So we've had that where we've kind of been the push. And then the flip side, like the spine one, we had 2 new spine surgeons come, which was amazing. And immediately they were like, hey, we got to do ERAS. We're at training programs where we had something similar to this. Can you help us out? Which is really great. So it's kind of I will say our team does a really good job of making the bandwidth when people come and ask. And so it is very rare, especially for ERAS, that someone would come and ask us and we wouldn't immediately start working on it. The cool thing is, like I said, like it's not limited to just your general surgeons. There's so many service lines in a pediatric hospital, and this can apply to any of them. I know who's from Denver here. Is it? Yeah, Leanne. So I did fellowship in Denver, and I worked with Ann Brockle a lot. And I'm gonna blank on his name, the urologist, but you guys had a urology ERAS one years ago, and we're definitely some of the early publishers in it. So I like that. It's not just us working with the same surgeon. It's us working with a bunch of surgeons.
There are a few questions in the chat that I'm happy to read, just so we can close the loop on them. Someone asked, have you explored the possibility of automated data extraction from the EHR for metric, estate, and tracking, generating an automated report to be displayed in a real-time dashboard or a similar infographic tool?
That's a great question. We've definitely explored it. We have not been able to accomplish it. So I will say it takes a lot of my time personally to do these databases. At a certain point, I became the champion of the data. And it's fine because I enjoy doing it. But yeah, in my dream, it would be a database that is automatically spitting out these dashboards, as opposed to the monthly reports we get are great, but they're just monthly reports. And so they have to go somewhere into some sort of ongoing database. I know that our hospital is capable of doing what this question is. We just have not been able to get truly a dedicated data person to work on this. We have a person who I have a good relationship with at this point, but this person is still, this is probably 1% of their job. They are definitely out doing other stuff. I was complaining to our group, last month was the first time I actually got put in a queue. And I thought I had made it to where I was like, oh, wait, what? You emailed me? I have to fill out an official request, dude? He's like, sorry, we're working on US News and World Report stuff. I'm like, are you kidding me? And so, no, I mean, it's definitely a goal. And, we say that's for ERAS. We want that for all of our pathways. This is not an ERAS specific thing. We would love better data. I assume it's a challenge for other people out there.
Another question in the chat was, do you use BPAs or pop-ups to point people to pathways while in the EHR?
Oh, Cerner, killing me. So no, we don't. So we have some built-in macro. I'll talk about our anesthesia software, which is very mouse and keyboard heavy, which is its own separate problem. So no, we don't have pop-ups. Where I know in Epic, you can build in macros where it literally will remind you to do this when it knows you're doing a certain case. And so no, we have looked into that. We don't have the capabilities. Again, like reason number a million for us is like people have to be able to pull these up. And we know it's not ideal because it's effort, it takes extra effort to go pull this up on a computer screen and look at it. We know it could be integrated. We do not. I don't know. The Epic people out there, I'm sure, have seen how it can be integrated, and it's awesome.
Right. Last question in the chat is, who owns the patient family education handouts?
I assume we do. Andrea, you're on here. Andrea is one of our program managers who has worked on the majority of these with me.
So I would say it's kind of a combination of the anesthesia APRNs have worked with myself and one of our other program managers to develop these. So I think the bottom line is we're the ones that kind of make sure that it stays up to date and we publish it and put it out. But if there's ever a question of if we need to change anything, the APRNs are reaching out to me.
That's a really good question, because we ran into that very early on, because they need to be printed out. And then it was, okay, where's the space in same day surgery? Where's the space in PAT? And who's ultimately, it's easy if you deliver 100 of them, but who's going to give us the next 100? And so we really had to work around that. I will say COVID has pushed a lot of our PAT to telehealth, which is a good thing for everybody. And it was a challenge for us initially. And then we figured out the QR code, which is great. It allows people to access it at any point without anything printed. So I would absolutely recommend that for people. Again, all of these things, we've had challenges on all aspects. I never would have thought we'd be in a 45-minute meeting about who prints out handouts for patients, but we have been there.
All right, I think there's one last question in the chat, and then I want to hand it over to Jared because I know he had a few things to say before we jump into some announcements. But just wanted to acknowledge Dr. Instack from Children's just said, we're sending empathy from Boston and the whole nation to your teams after the tragic event yesterday. So sad day.
Thank you.
Acknowledge that. Last question was, is the data methodology you use for the ERAS unique, or do you use the same method for all other Mercy pathways?
Definitely unique. And I will say, even within each pathway is unique in itself. Again, they have some core stuff like the, demographics and what the surgery was, but each ERAS pathway tracks different stuff. A lot of these patients would never get a nerve block for their surgery. And so that's something we don't track on some, it's some we track on others. The ICU one's a great one. I mean, there's a whole ICU section. The majority of these patients are not going to the ICU. And so, like I said, each one is unique. They're probably all 85% similar, Again, why it's really important to have that dedicated IT person. If you can get one who can really roll with you in understanding which patients may need what. And again, I can't tell you how many times I've screenshotted something from the EMR to the data person to be like, can you help me pull this? Because they just have no idea what I'm talking about.
All right. If there are any other questions too, I'm happy to kind of help field those after if people want to send emails to the inbox. But otherwise, I'll hand it over to Jared if you. I'm not sure if you have slides or you want me to just share with the slides.
No, there's no slides.
Okay.
I just want to introduce myself. I'm Jared Zine. I'm the director of evidence-based practice at Children's Mercy. And so this is unrelated to Todd's presentation, even though it's the same institution. So I'm actually working on a patient and family engagement survey. So I'm doing a mixed methods study of, but the first part of this is looking. I'm going to be sending out a survey in the next couple weeks. My goal is to have it out in the next couple weeks to this group, and I'm looking. Particularly, I'm interested in knowing of like how all the different hospitals are engaging patients and families in the development of their clinical pathways. So this is going to be, it's not a long survey. It's going to be around 34 questions. It should take takes around about 10 minutes to take. And it's just going to be asking questions about patient and family engagement at your institution around clinical pathways, your own personal attitudes towards it, and personal skills around patient and family engagement. So it's a pretty brief survey, and the goal ultimately is, could this eventually lead to the creation of some standardized work and some standardized tools that we could all use and implement within our institutions to better engage patients and families? Because we have it's like I have ways that we're doing it at our institution, but we want to know like how everybody else is doing it, if people who are doing it well and those who aren't doing it well. And the other things there is a demographics on it. It's not asking for personal information. It's really going to be asking about your department's demographics, the size, how old it is, the resources around it and stuff. At the end of the survey, there'll be an option. So there'll be an opportunity to participate in some focus groups. And then also I will be, if you want, the opportunity will be to actually request what the kind of aggregate of the results are. So I'm planning to, like, after I get the survey in, I'll compile the information and I'll send it out to the group so everybody can kind of get an idea of what those results are. So if you want, that opportunity will be available also for the group. So in the next couple of weeks, if you get a red cap survey from me, it is not spam. It is not a phishing attempt. But what I'll do is I'll be sending it to your direct emails, and I'll also be sending it. I'll make note of it. Like I'll put it on Slack to notify everybody to expect it, and that this is that this is coming out and stuff. So when you see it, I'd really appreciate if getting as many people to fill out the survey. I think it could be really helpful for everybody. So thank you.
Thank you so much. All right, I'm just going to share my screen. All right, a couple quick things. So I was just going to give a quick update on sponsorship. Last time we had discussed that we would be pursuing partnership with AAP. That work is still ongoing, so not much of an update there. One thing we did kind of want to just preliminarily introduce to the group is that we are pursuing opportunities for a national conference. So more to come there. Not a ton of details, but just to let you know that there are things kind of in the works there, and hopefully we're able to have an update for you at the next meeting. Another item, we were looking for other members that may be interested in helping to plan content for the quarterly meetings as far as finding presenters and kind of organizing all of that. So I'm going to drop our email in the chat. If anyone is interested, if they just want to respond to pathways4kidsinfo@gmail.com, we'll just connect you with the subcommittee of the steering committee that is essentially working to plan the quarterly meeting. So anybody who's interested in that, please let us know. Also wanted to do a quick literature spotlight. We did talk about the article that we were anxiously awaiting to be published from regarding race, ethnicity, and ancestry in clinical pathways, a framework for evaluation. So I did drop the link to the article in the chat as well, just because we've talked about it in other meetings. We just wanted to let people know that that has officially been published, which is very exciting. As far as announcements, I think that's it. If anyone else has anything else they want to chime in, please feel free. But otherwise, I'm going to turn it over to Courtney to give some regulatory updates.
Hi there. I'm Courtney Titus. I'm a PA over at Johns Hopkins All Children's Hospital in St. Petersburg, and I'm the director of our Pathways program. Oh, man, did you mind? Okay. So we were discussing in our steering committee meeting, I think many of us are kind of in the same world. And speaking of US news, there's a lot of things that we all kind of can relate to. And one of the topics that came up in the conversation was about US news had recently dropped their new requirements or their points that you can get through their reporting system. So I just wanted to make sure everybody was aware, if your system reports out to US News, that high flow nasal cannula therapy and the BRUI, brief resolved unexplained event, are new this year. And so it might be something that I know our team is working on, making sure that we've accomplished both those pathways in the next year. So I just wanted to make sure you guys knew about that. The others have been there, so those are not new points, but high flow nasal cannula and BRUI do count. All right, and then next slide. And those are under the pulm section. If you're wondering, if you're trying to find them, they're under the pulmonary section. And then there's a couple other kind of just things I keep hearing. And so we just thought this is a really great place to share this information. So my trauma surgeons had advised me and told me that this year they recently added a clinical pathway recommendation from the American College of Surgeons. They have, I actually went through their whole document. They have several areas that they recommend having pathways and where it keeps them accredited. And so one of the newest ones is the pediatric non-accidental trauma pathway. They have had massive transfusion, anticoagulation reversal, and the rest that are kind of listed there. But the newest one is the non-accidental trauma for pediatric patients. So I thought that was relevant for this group. And then lastly, I've been working personally with our antibiotic stewardship. So this is all isn't not necessarily new information, but I didn't know it, so I thought I would share it here, which is that the Joint Commission in January of 2023 had added some elements performance in medication management. And so they had included that antibiotic stewardship implements at least 2 evidence-based guidelines. And the terms in all of these are usually really vague. They don't necessarily spell out what they mean by pathways or guidelines. So you can kind of interpret it. But for us, we're trying to work on pathways that kind of adhere to the TJC's recommendations. So just wanted to kind of point those things out. Sometimes I think it's helpful. If you have questions, we actually have a channel on Slack that's US News. If you have thoughts or ways that you guys have been able to make this happen for your teams. But just wanted to start that conversation here, and we can continue it over in Slack.
Great, I think that's about it as far as content is concerned. So I'm going to stop sharing to see if anyone else has any other comments. I'll take a peek in the chat to see if there's anything else we missed.
Jason, just one other kind of shout out for the Slack. Check if you haven't had a chance to check it out, the channel for Pathways for Kids, definitely check it out. Like we mentioned earlier, there are a couple channels now on there that have topics, different topic areas for what people might be asking questions about. So definitely go there, post a question. I've noticed that some people are replying to questions there, and there's some community starting to evolve around there. So check it out.
Anything else from anyone? Otherwise, we'll give people a few minutes before their next meeting.
Just as a final, I'll just say, if you haven't gone to the Pathways for Kids website, there is a membership login that if you're a member, you should have access to, and that will be where all these recordings will be, as well as the slides. So I'll add Todd's slides, and they're all locked down and they're password protected, but it's a nice place to see old meetings too. So that's all I have.
Right. If you have any questions, please feel free to send them to the inbox and we'll triage from there. But otherwise, everybody have a great day.
Thanks Thank so much.